Hello everyone, this is Faisal Khan. I am Medical Director of Endoscopy and Interventional Pulmonology at Franciscan Health, Indianapolis. Relevant to this talk, one introduction, as this talk is more about the utilization patterns after deployment of a robotic bronchoscopy platform, specifically MONARCH in this case. We are located in Indiana, and our program was the first program in the state of Indiana to deploy a robotic platform. So this leads us into the purpose of the study that I'm going to talk about. This is a small study, but a very relevant study, especially for the programs that are out in a non-academic or a community setting. Just a little background for our institute. We are a busy cancer program, and we had been utilizing the previous platforms of navigation bronchoscopy for more than 10 years, and we were fairly busy in that sense. But back in 2018, 2019, when we decided to adapt the robotic platform, even though from a physician standpoint, it made perfect clinical sense to acquire this platform, the reality is that because of the cost involved and the some of the unknowns at the time, because it was really a new technology, there are some questions that were asked, rightly so, by the hospital administration in terms of when making the business case to purchase this equipment and whatever comes along with that. So it's a huge investment from the hospital part. And just broadly speaking, in any community hospital, as many of you may have experience with this, whenever you're asking for a purchase, you should have a good, solid clinical basis for that, as well as to a great extent financial basis for that, that it should make sense for that organization to invest in a certain technology. So when I started looking into acquiring the platform, even though as the medical director of the department, I knew that this is the way to go, the questions asked were broadly in two categories. One was the clinical argument for it in terms of efficacy and or how it make a difference on top of what we already had at the time, which were the older platforms. And the second was, is there any potential in terms of expanding the program and have a financial return on investment if we go ahead and adapt this program and platform. And the reality is that at that time, there was no relevant data to quote and make a business case whether there is any precedent out there in terms of assuring that adoption of this new technology would lead to something beneficial for the organization in terms of utilization patterns and in expanding the program footprint in the local in our region. So I would say the blessing was that we've had historically success at our organization as a program, as an interventional pulmonary program, and some of that had earned us some credibility. So for me personally, it was pulling some strings, but we were able to acquire the technology. But that led me into thinking that there are so many other programs out there in the country that probably are looking for the same answers that were asked of me. So if we can look at the data internally and produce something which may help other programs kind of to justify if they need a robotic platform, because there are so many other physicians out there who are very adept at doing bronchoscopy. They are busy in their lung programs, but this is the hurdle that they have to face when they ask for an advanced platform. So from the get-go, when we acquired the robot in 2019, we did our first case end of July 2019, and I would say first week of August 2019. The mindset was that we are going to look at the data as a community hospital, because up until that time, most of the studies were done in an academic center, and they were mostly feasibility study or safety studies. Some were efficacy studies. So, and they were in a very controlled environment, as any large study in an academic environment is. So this, my intention was to look at the data from two perspectives. One was to look at the clinical efficacy and the outcomes in the real world of a community hospital practice. And the second was to look at the utilization pattern in terms of the growth of the program. So we published our first paper, which was a multi-center review of 3 hospitals, and that was published in BMC Pulmonary Medicine earlier this year. And that basically, I won't go in the details of that, but basically corroborated that the outcomes in terms of diagnostic yield, complications, efficacy were on par with the other published studies for the robotic platforms, and better than the previous legacy technologies of the EMN. And so that was a feel-good review that this did make a difference, and we were taking more smaller nodules and peripheral nodules compared to the previous platform. So that answered the clinical aspect of it, that this technology works in a community setting if deployed correctly and being utilized by the physicians who are trained and are kind of day in, day out doing these procedures. Having said that, the second question was the program utilization and the program growth. And that's where today's talk is somewhat relevant, and I hope that this will help other hospitals and system in making some argument. So the layout of our practices, we are located, we are a Franciscan hospital, is a 13 hospital system, mostly in Indiana and some presence in Illinois. And the Franciscan Indianapolis is the biggest hospital in the system. We have a very comprehensive thoracic oncology program, and we were the first to implement an interventional pulmonary program back in 2013. And then, as I mentioned before, we were the first to deploy a robot in our practice. And we were busy before, so this study was done to look at whether the robot did make any impact in terms of growing the program and increasing the utility in terms of accessing the peripheral lung, especially in parallel as the lung screening volumes have been going up the last few years as well. So the methodology we adopted, of course, we were the single center, and it was a retrospective review. We are a community hospital, and I'm the only interventional pulmonologist here. My practice does involve 14 other pulmonologists in my partnership, but they don't do robotic bronchoscopy, and no one else is trained in robot, at least at that time. And we looked at the procedures that we did in 2018 when we did not have a robot. That was the last year using the EMN platform. And then we looked at the data of 2020, which was the first full year of doing the robotic cases, and then the 2021. So basically 2 years after and 1 year before. We skipped 2019 because that was a transition year where for the first 6-7 months we did the previous platform, and then the latter half of that year we utilized the robotic platform. And what we looked at was basically transbronchial sampling of the peripheral lung nodules. Now here you see we have used the acronym TBBX. This encompasses both transbronchial forceps biopsy as well as FNA with a needle. So I know some people specifically use TBPX for forceps, but this for this study purpose, this terminology represents both. So we looked at the transbronchial sampling utilization per year. And then also the secondary aspect we looked at is how many of those patients who underwent specifically robotic bronchoscopy ended up continuing their care at the hospital after the biopsy, and as in general, and as well as specifically to any particular lung cancer treatment like surgery, rad-onc, or chemo. So, and then the patient population we kind of divided into two. Internal referrals, meaning referrals coming for robotic bronchoscopy and biopsy from within the system. Most of these physicians were part of my practice. I'm not hospital employed, so but we are a large practice solely providing pulmonary service. So physicians affiliated with the Franciscan system, either oncologist or pulmonologist, and in some cases primary care. And then new referrals coming from physicians coming from outside the hospital system. So again, we are in the south of Indianapolis, and our system covers mostly South Central and South Indiana. And there are a lot of peripheral regional hospitals that refer to us as a tertiary center. So we wanted to see was there any uptake in the referrals from those hospital systems for this particular utilization. And to look at as a marker of what would tell us whether there's a true growth, we looked at we made basically the newly referred patient as a proxy or the measuring tool, because we assumed that any increase in the internal referrals would have occurred irrespective, because that was the pattern before. But we also wanted to see if there's any increase in the internal referrals, why would that be? Because was that a shift more from IR towards robotic bronchoscopy, or from surgical wedge biopsy towards robotic bronchoscopy, those kind of things, just to get an idea of whether there's going to be a shift or not. And then, of course, those data was analyzed, and we kind of just basically kept it simple to see how many fold increase did we observe when we looked at it. So in total, over from 2018 January till end of 2021 December, that is a 4-year time, we looked at about 616 patients. Of course, 474 patients were analyzed because we, as I said, we omitted 2018, which was a transition year. And the breakdown from an insurance standpoint is pretty typical of how our hospital in general, about 70% Medicare, 20% private insurance, and then 10% either TRICARE or self-pay. And about 600 and some patients total, which translated to about equal amount of procedures, and the procedures analyzed. Some patients might have received more than one procedure, but I mean, they're pretty equal overall. So here are the results. In total, as you can see, in 2018, we did about, I did about 35 EMN cases. And again, just to give you a perspective, our program up until that time was doing a fair amount of EMN, but not that high. But we were mostly high on EBUS and mediastinal staging, and also inking the nodules for the surgeons to do wedge biopsies and so forth. So in 2018, just purely the EMN transbronchial sampling that we did was 35. In 2020, it went up to 199, which was a 5.7-fold increase total patients. And then 2021, we were up at 246, which was a 7-time-fold increase. Now, if you break that down, not only the internal referrals for bronchoscopic biopsies went up, but the main driver for this growth, this exponential growth, was the new referrals coming from outside the system. As you can see in the middle chart there, up until 2018, we had only 3 patients referred for bronchoscopic biopsy from outside the system. In 2020, it went up to 50, which was almost a 17-fold increase. And in 2021, it was 80, which was 26, almost 27-fold increase. So double-digit increase, exponential, and I can say with great confidence that since then the graph has not plateaued. It's on the rise. As to the internal referrals, again, same growth pattern where you went from 32 to 149, which was almost a 5-fold, and then 166, which was a 5.2 fold increase. So, I mean, across the board, that was the case. Now, I did not put that slide here, but we looked at the utilization pattern for interventional radiology TTNA referrals. And between 2018 and 2021, their volume was stayed almost the same, was kind of like a plateau, hovering between 94 to 100 cases per year. So it was not that this pattern reflects any change of or shift of pattern from IR towards this, but this is just a new volume. And just my thoughts or my internal review of the data on this, one of the explanation I can give is that our tolerance for taking smaller and more challenging nodule compared to the previous platform really changed, and we are taking much more challenging and smaller nodule in difficult locations. And as that word got out and our results were our biggest advocate, and people saw, and the referring physician saw, that when a patient comes and gets a biopsy, they do get the answer, and the false negative rate is low, which is corroborated by the study I mentioned earlier of our performance. Then that also fed into the confidence for referral both internally and externally, and that's what we are seeing here in the growth. As regards to the follow-up treatments, again, I would point out that in 2018, none of the 3 patients who got bronchoscopic biopsy from outside system stayed within the system. And again, one of our, I think, strong points as a tertiary center for these procedures and IP in general is that I'm an extra conscious that if a system is referring to us for a particular service, we go out of our way to ensure that those patients are sent back to the referring physician so that they can make a choice whether they want to keep the patients continue further treatment in their system, or they want us to take over. So it's so I mean, our philosophy is we don't want to take over the patient completely without the consent of the patient and the referring physician. It's just professional that we standard that we try to stick to, and I think that philosophy has also helped in terms of referrals coming to our system, because once the referring physician gained the confidence that we don't keep the patient if that's not the desire of the referring physician and the patient, then they feel comfortable referring to us, knowing that our communication back and forth is open and we are respectful for that relationship. But having said that, naturally, some patients preferred to stay. Some referring physicians have started to gain our confidence, and they have started to shift their pattern of oncology and thoracic surgery and radiation oncology services. So they feel comfortable asking us to keep the patient for further treatment after biopsy. And that's what's reflected here. 2018, no one stayed. 2020, out of the 50 that were referred for the biopsy, of course, not everyone was cancer, but out of those 50 in general that were referred, 5 stayed, so about a 10% retention rate. And then 2021, out of the 80 some patients that were sent for the biopsy, again, understanding that not everyone had cancer in those, about 13 decided to continue oncology treatment in our center. So again, about a 15–16% of that population. So again, when you're talking to the administrators and you're making a business plan, these are the relevant numbers, and you can kind of extrapolate based on your historic data about this. Total patients, same pattern we saw, that 2018, again, we had about 17 patients staying within the system, but then as with each year, that number started going up. And if you look at the breakdown, it resulted in 21 surgeries, 82 radiation procedures, 60 systemic therapies, and 7 patients for palliative and supportive care. So again, trend in general was in parallel with the trend for the new referrals. And again, I feel comfortable in saying that 2022 and 2023, we have seen the same pattern of growth, and it continues to grow. So some of the limitations, I think you can take it either way. If you recall, we just have come out of the COVID era. So COVID hit us 2019, end of 2019. So this data is during the COVID, and we all know that for many weeks and many days in a row, there were times then when the hospital had to shut down elective procedures and so forth. So despite that, I mean, any concern for a cancer and a biopsy was considered as an not emergent but an urgent procedure. So we did continue to do these procedures, and the question is that despite COVID, if this is the pattern we saw, would we have seen a higher trend if it was not COVID? You can make an argument, yes. On the flip side, you can also make an argument that the smaller hospitals probably had a lower threshold of diverting patients during COVID era, and that could have been the case for our exponential growth, because we were the bigger hospital and we were getting a lot of COVID patients and transfers. So we were getting a higher transfer rate in general for everything. But having said that, as I mentioned before, the pattern has not plateaued even after COVID, and we continue to grow. So I see it from, you can call it a biased opinion, but I see the growth even to this date. And I think we would have been much higher during those years compared to what the data shows. Just to, again, validate my observation, as I mentioned, I was the only interventional pulmonologist, but I've been looking for a second partner, and I'm fortunate to now have acquired one who will be joining us in 2024. Again, the business case was that one physician has been completely saturated, and we're outrunning our capacity. So that's that. The second is whether any other community-related factors where a loss of thoracic surgeon at a community hospital might have diverted their pattern from surgical wedge biopsy for high-risk patients towards sending for a bronchoscopic biopsy, knowing that we had that technology and we were putting good results. Possible. One of our referring hospitals did lose a surgeon, but that was one out of many. So I would say that even though that might have influenced, but I find it hard to see how that would have globally impacted the trend that we are seeing. So that being said, I think the conclusion is that after the adoption of the MONARCH robotic platform, the total number of the bronchoscopic procedures went up exponentially, both from internal and external referrals, without scavenging on the interventional radiology procedures. And the key driver for this increased utilization was the influx from outside the system and the expansion of our footprint as a regional program. And again, I mean, I think such studies are important, especially from a program development standpoint. I know most, of course, the primary interest is the safety of the patient and the efficacy of the technology and the outcomes. For sure, that always takes the precedence. But when it comes to deployment of technologies that have a reasonable or a substantial cost, you got to justify that if you deploy it, what would be the utilization, because any administrator would ask the question, whether even if the technology is effective, what they want to make sure is that it'll grow the program and not go wasted by underutilization. So I think this study kind of validates to a certain extent that if done in the right setting and done by a team that is already wired to deliver such services, then there is a positive impact both from clinical as well as utilization standpoint. So with that, I will conclude and I'll be happy to answer any questions.